This is Roscoe Butler. 1, 2, 3, 4, 5.
Wonderful, thank you.
Joy Elam, 1, 2, 3, 4, 5.
Perfect, Miss Elam. Miss Elam, you're a little washed out. From light. Is there like a light shining on your face, perhaps, or?
I know it's above me, but let me try to turn it out. I don't know if it will help somehow.
That might. We can try it and see if that makes it
Okay.
better.
Any better?
I think that's a little bit better.
Okay.
Hi, good morning again. If someone dialed in, called into the hearing or the WebEx perhaps from a 602 area code, could they please identify themselves? If not, we're going to have to remove that person from participating.
They can't hear us.
Can you hear me?
I'm sorry, who was that?
Dave McIntyre.
Okay, thank you, sir.
Hi to all of our witnesses. This is Elizabeth McKenzie. I just wanted to alert you to the fact that HVAC timer is now up on the screen. So if you want to go ahead and if you hover over it, you'll see a little icon that looks like a pin. You can go ahead and pin it so it won't move around and you'll always be able to see it clearly.
You ready to begin the hearing?
I am.
Please provide a 5-second countdown.
5, 4, 3, 2, 1. Good morning. I call this hearing to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. We have a number of members and witnesses participating remotely today. Before we proceed, I'd like to go over some items for those participating remotely. First, if you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so those issues can be resolved immediately. Members participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render them unable to fully participate on camera. It is committee policy that members participating remotely will remain muted when not recognized, just like turning your microphone on and off during an in-person hearing. This is out of courtesy to all members on the committee so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for a couple of seconds before speaking so that we will be able to hear everything you say and so that it will be captured on the live stream of this hearing. If you wish to be recognized, please raise your hand using the WebEx raise hand function, unmute your microphone, and ask to be recognized. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearings@mail.house.gov. It will be uploaded to the committee document repository. Please keep in mind that you will need to refresh the repository page as it does not automatically update. Without objection, members will be recognized in order of committee seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. Does any member have a question about the conduct of this hearing with members participating remotely? Also with us today are our full committee chairman, Mark Takano, and ranking member Phil Rose. Thank you both for being here. I now recognize myself for an opening statement. Nearly 16 years ago, on June 6, 2019, VA launched the Mission Act Community Care Benefit. Despite what the president might say at his rallies and in the media, VA community care is not a new benefit. It's actually been around since at least 1945. However, the Mission Act overhauled the Veterans Choice Program that was created in 2014 and significantly expanded veterans' eligibility for referral to community providers when there are lengthy wait times for appointments at VA medical facilities or when needed services are not readily available at VA. Today, we will examine the extent to which VA is meeting the goal of delivering timely care through the Mission Act Community Care Program more than a year into its implementation. Late last month, VA provided the committee data on veterans' wait times for appointments both within VA medical facilities and in the community. VA's most recent data show that in fiscal year 2020, from October 2019 through June 2020, veterans waited an average of 41.9 days from the date of request for routine specialty care appointments with community providers, with 21.9 of those days accounted for by a bureaucratic, administratively burdensome appointment scheduling process. In contrast, these VA data show the appointments for specialty care at VA medical facilities are scheduled in less than a third of the time it takes to schedule community care appointments, 6.8 days on average. When the President signed the Mission Act into law on June 6, 2018, he promised that the expansion of VA's community care program would end the problem of veterans, quote, standing in line for weeks and weeks and weeks to see a doctor. He also said, quote, it's going to be great. This morning's hearing is the 5th oversight hearing held by the subcommittee or the full committee to examine VA's implementation of the Mission Act Community Care Benefit. For the first time, we have data that clearly shows this program is not great, and it is not delivering on President Trump's promise to veterans of more timely care. It should come as no surprise that veterans are still standing in line for weeks and weeks and weeks to see community providers. This is because, as you may have read in a new report GAO issued on Monday, and as you will hear from our GAO witness this morning, VA designed an appointment scheduling process that allows up to 19 days for staff at VA medical facilities to schedule veterans' community care appointments. Furthermore, GAO has recommended since 2013 that the department establish an overall wait time goal for community care. Despite concurring with this recommendation and a related one GAO made at the time the Mission Act was enacted in 2018, VA has never specified the maximum number of days veterans should have to wait to complete appointments with community providers. On the other hand, VA has established wait time goals for appointments delivered at the department's medical facilities. The Mission Act required VA to designate access standards for the new community care program, and these serve as one criterion under which veterans are eligible for a referral to the community. According to VA's access standards, veterans are offered referrals to community providers when they cannot obtain primary care or mental health appointments at VA medical facilities within 20 days or specialty care appointments within 28 days. What veterans most likely do not know is that if they opt for community care, it will quite often take longer for them to access community care appointments than it otherwise would take for them to obtain appointments at VA medical facilities. VA does not publish community care wait time data, and schedulers are not required to inform veterans of average wait times for community care when they offer community care referrals. Given VA's lack of action on GAO's long-standing recommendations related to an overall wait time goal for community care, GAO has now recommended that Congress take legislative action to require VA to establish one. Yesterday, less than 36 hours after GAO issued its report, I introduced the VA Community Care Wait Time Transparency Act of 2020, which requires VA to apply the same wait time goal to community care that it already applies to care veterans receive at VA medical facilities, a goal that is equal to the 20-day and 28-day access standards VA established under the Mission Act. If VA is applying this wait time threshold to its own facilities and referring veterans to the community when VA appointments aren't available within those timeframes, then VA should be holding community providers to the same standard. And at the very least, VA should offer veterans information that will empower them to make more informed decisions about whether they should wait for appointments at VA facilities or seek appointments with community providers. My bill also requires VA to publish community care wait time data on a public-facing website to include average wait times and the percentage of appointments that occur within the department's established wait time goal. That website must be searchable by zip code, specialty, and VA-MC, and similar to VA's existing website for wait times for appointments at VA medical facilities. While our legislative days are numbered between now and the end of the year, I look forward to working with my colleagues to pass legislation as soon as possible that will require VA to finally act on the recommendation GAO made 7 years ago. Together, we need to work together to deliver on the promise of the Mission Act Community Care Program and better ensure that veterans' access to care, whether they choose to receive care at VA medical facilities or in the community, is not impeded. So with that, I will now recognize Ranking Member Dunn to deliver any opening remarks he may have. Dr. Dunn?
Thank you very much, Chairwoman Brownlee. I'm excited to be here today to continue the series of hearings our subcommittee has held in Congress on the Veterans Community Care Program. The Community Care Program was established last congressional session in the Mission Act, and it was intended to replace the Choice and Department of Veteran Affairs other community care authorities with a single streamlined authority with access to care and empower the veterans with more choices and greater control into where and how to use the health care benefits that they have earned. Today's hearing will assess the timeliness of care delivered through that program by the VA's nationwide network of more than 727,000 community providers. As members of this committee know too well, accurately gauging access to care, either in-house or in the community, is no easy feat. And the VA has struggled with this in the past. I think the civilian side has too. The Government Accountability Office released a report Monday outlining the VA's continuing challenges in this regard, and I'm glad that they're with us virtually this morning to share their recommendations for improvement. I'm also glad that representatives from the Veterans Service Organizations are here to virtually provide the veterans' perspective, and TriWest, one of VA's two community care third-party administrators, is also here to virtually provide their community perspective. We are joined in person by three senior leaders from the VA Health Administration. I appreciate all of you taking time to discuss the efforts the VA is making to shorten wait times and to ensure that every veteran has timely access to high-quality care. I ask all members of the House and the public to keep in mind that the healthcare environment we are working in now and for the last 8 months is extraordinarily complicated as a result of COVID-19. We are facing a confusing array of options regarding precautionary procedures, defining the population at risk, and even the appropriate treatments that are available. I've said this before, and I'll say it again, the VA healthcare system has done a great deal that they can be proud of in the department's response to the pandemic. No other healthcare system in America has come to the aid of more nursing homes, other hospitals, and the public health systems than the VA. The VA healthcare workers, other employees, and the leadership of the VA stepped up to care for veterans and civilians in a selfless fashion all across America, and their heroic efforts should be celebrated and supported. That said, we remain in a critical situation with respect to ensuring preparedness for a possible resurgence of this virus in the fall and deploying a whole new set of treatments and tests in regard to these patients that have been developed just in the last 8 months. We must also ensure that the backlog in care that COVID-19 created is addressed effectively, fairly, transparently, and without undue delay. We want no veteran left behind or falling through the cracks. Community care has always been an irreplaceable complement to the VA healthcare system. That is particularly true now. I'm hoping today's hearing will give us an opportunity to hear about the VA's efforts to comb through the millions of appointments that were canceled due to COVID-19 and working with their community partners to be certain our veterans receive the care they need and deserve in spite of the stress that COVID-19 has put on our healthcare system. I look forward to this conversation this morning, and with that, I yield back.
Thank you, Dr. Dunn. Chairman Takano, do you have any opening remarks?
I do, Ms. Brownlee. Thank you, Ms. Brownlee, for Chairwoman Brownlee for holding this hearing on this important topic and for summarizing so well the problem before us. More than a year after the D-Day anniversary of the go-live of the Mission Act Community Care Program, VA is not accomplishing one of this program's primary objectives, speeding up veterans' access to care. Together with our colleagues in the Senate, veteran service organizations, and other key stakeholders, this committee worked diligently in 2018 to craft what became the VA Mission Act. While ensuring that VA would remain the primary provider and central coordinator of veterans' health care, we developed legislation that was also intended to improve veterans' access to care and make them feel empowered to make choices. However, based on the findings of GAO's new report, it's hard to see how either of these two things are true. In the wake of the wait time scandal of 2014, access to care in the community was touted as the cure-all. Yet, GAO's latest report suggests veterans are potentially waiting longer to access care in the community than if they opted to remain at VA because of an overly bureaucratic, administratively burdensome appointment scheduling process. Unfortunately, veterans largely don't know this and are forced to make important decisions about their health care without knowing all the facts. And to that end, I applaud Chairwoman Brownlee's introduction of legislation yesterday that will mandate VA establish the same wait time goal for community care that it already applies to care veterans receive at VA medical facilities. The VA Community Care Wait Time Transparency Act of 2020 will also require VA to publish community care wait time data on a public-facing website to include average wait times and the percentage of appointments that occur within the department's established wait time goal. This legislation will further enhance veterans' ability to make informed decisions about their health care. I hope to hear more from our witnesses this morning about how the department and its contractors intend to address other impediments to veterans' timely access to community care. However, before I yield back, I would be remiss if I didn't take a moment this morning to express my concern about VA's readiness to expand the program of comprehensive assistance for family caregivers, or caregiver program, to pre-9/11 veterans starting tomorrow. I know that's not the focus of today's hearing, but I do hope we can take a few moments with the VA leaders present today to discuss VA's preparation for implementing the long-awaited expansion of the caregiver program, which was the other signature piece of the Mission Act. This program provides monthly stipends, training, mental health services, and other support to primary caregivers of veterans with serious injuries that were incurred or aggravated in the line of duty. The Mission Act required VA to expand the program to eligible veterans of all eras, starting with those who served before May 7, 1975, and later expanding to all other veterans that served prior to 9/11. Before launching this expansion, the Mission Act required the Secretary of Veterans Affairs to certify a new IT system for processing applications and caregiver stipends and performing other key administrative functions. I want to be clear, it was Congress's intent that this IT system be certified before VA begins accepting applications from veterans who will be newly eligible for the caregiver program. I must say that I am worried, quite worried, that we're here just one day before the caregiver program expansion goes live in accordance with regulations that were finalized over the summer, and VA still has not certified the new IT system it has been developing since the Mission Act passed more than 2 years ago. Let me repeat that, more than 2 years ago. As you may know, I was an educator before serving in Congress, and I hope you'll forgive me for the following analogy, but the way I see it, VA is behaving like a student who crams for the final exam after never having attended class or turned in any homework assignments the entire semester. It is my understanding that VA only began the final phase of user acceptance testing for this new IT system within the last couple of weeks, and that some glitches, which have not been explained to the committee, have been identified. It is frustrating that VA has not been forthcoming or responsive to our staff's requests for additional information. Nevertheless, VA continues to promise that its contractors will fix the glitches, and this IT system will in fact be ready when the caregiver program expansion begins tomorrow. Once again, VA has had more than 2 years to prepare for this exam, but we are right down to the wire here. This expansion is set to go live tomorrow. And thousands of pre-9/11 veterans and their caregivers have waited more than a decade to be eligible to participate in this program. There's a lot riding on this, and I certainly hope that the IT system is up to the task. Thank you, Chairwoman Brownlee, and I yield back.
Thank you, Chairman Takano. I'll now turn to Ranking Member Rowe. Dr. Rowe, you're recognized. No opening comments? Very good. Then we will move on to our witnesses for today's one hearing panel. We are joined by the co-authors of the independent budget, Mr. Roscoe Butler of Paralyzed Veterans of America, who is accompanied by his colleagues, Ms. Joy Elam of Disabled American Veterans and Mr. Patrick Murray of Veterans of Foreign Affairs. They are joining us remotely. We also have Ms. Sharon Silas, a director from the U.S. Government Accountability Office's Health Care Team. She is also joining us remotely. Next, here in the hearing room, we have Dr. Steve Lieberman, Acting Principal Deputy Undersecretary for Health from VA, who is accompanied in person by Dr. Mark Upton, an Acting Assistant Undersecretary for Health for Community Care, and participating remotely, Dr. Jennifer McDonald, Chief Consultant to the Principal Deputy Undersecretary of Health. And finally, we have Mr. David McIntyre, President and CEO of TriWest Healthcare Alliance, joining us remotely today. We will now hear the prepared statements from our witnesses. For those participating remotely, I will remind you to please pause for 2 or 3 seconds before speaking so that the recording will capture all of your words, and please remember to do so when answering members' questions as well. Your written statements in full will be included in the hearing record without objection. Mr. Butler, you are recognized for 5 minutes.
Don and members of the subcommittee, the co-authors of the independent budget, DAV, PVA, and VFW, are pleased to present our views examining the timeliness of veterans' access to community care since the VA implemented the Mission Act. To help prepare for this hearing, we reached out to our members to gain a better understanding of how COVID-19 has impacted veterans' access to health. The feedback we received represents a snapshot of veterans' experience and the challenges they face. For example, VFW recently asked its members to report their experiences, and veterans in several states reported ongoing problems. Issues such as veterans receiving bills, the provider no longer participating in the program, wait, where I acknowledge appointments that were carrying provider temporary closure. We also contacted a few VA medical centers to solicit feedback and were informed they are just now starting to contact veterans to reschedule appointments. Based on those discussions and the volumes of referrals that apparently needed to be rescheduled, the bubble of deferred care is likely to create access problems in both VA and the community as operations resume. Access to and timeliness of needed care must be closely monitored over the next several months so no veteran has scheduled appointments. They should be informing veterans about all their care options, including wait time and availability for care. VA staff at one site informed us appointments were being rescheduled, but veterans were not being informed that care was available at VA and that it might be the timeliness option. Instead, veterans were scheduled with a CCN provider. In addition to making veterans aware of their options for care with the integrated networks, it is essential that they are provided evidence-based information in order to make truly informed decisions about their care. We confirmed through VA sites we contacted, VA was trying to stand up referral coordination agreements to manage rescheduling veterans appointments. The feedback received highlighted a process that is still being developed and provides little opportunity for staff to make needed adjustments. Based on the volume of consults that needed to be rescheduled, employees also expressed concerns about inadequate staffing levels for both nurse care coordinators and schedulers. We hope the subcommittee will continue to monitor the implementation phase of standing up local community care coordination teams and veterans' access to timely community services. Also, to get a better understanding how the Veteran Community Care Program is performing, we recommend GAO conduct a thorough assessment of the program, specifically looking into the process for establishing referrals for community care consults, appointment scheduling, and how VA is engaging veterans prior to referring them to a community network provider. Finally, we would like to bring to your attention concerns for veterans regarding VA's community providers inappropriately billing veterans for care authorized by VA. All three organizations, DAV, PVA, and VFW, have reported these problems. To give you an idea of the scope of the problem, a section of VFW's recent Our Care survey asked about VA coordinated care, community care, and over a third of respondents reported receiving a bill. PVA has alerted VA Central Office about billing issues veterans are facing. When veterans get bombarded with bills, overdue notices, and bill collection threats, they not only get frustrated and concerned, but anxious and worried about their credit records and possible lawsuits. This is unacceptable, and we urge VA to redouble its efforts to ensure CCN providers are informed and understand that veterans are not to be billed for VA-approved care through CCN. Again, we thank you for the opportunity to submit our views on access to community care, and we look forward to answering any questions you may have.
Thank you, Mr. Butler. Ms. Silas, you are now recognized for 5 minutes, and again, please just remember to pause for a couple of seconds after you unmute.
Chairwoman Brownlee, Ranking Member Dunn, Chairman Takano, Ranking Member Rowe, and members of the subcommittee. Thank you for the opportunity to be here today to discuss the findings from our recently released report on the implementation of the Veterans Community Care Program. VA has been providing veterans with access to health care from their community providers since 1945. During the last decade, Congress has taken steps to expand the availability of community care for veterans. And while most veterans still receive their health care services at VA facilities, the number of veterans receiving medical care through their community provider has increased 77% since 2014. In 2019, nearly 2 million veterans received care through the Community Care Program. The 2018 Mission Act established the Veterans Community Care Program and is the latest iteration of VA's community care. VA had 1 year to implement the Veterans Community Care Program, a large and complex undertaking that came with many risks and challenges. However, VA's experience with the Choice Program, a precursor to the Veterans Community Care Program, provided VA with an opportunity to avoid the operational and oversight weaknesses GAO identified in the Choice Program. Specifically, GAO reviewed the Choice Program's appointment scheduling process in 2018 and found, among other issues, a lack of trained staff and improper processes and policies to effectively manage the program and ensure veterans timely access to care. GAO made 10 recommendations that were framed to incorporate lessons learned from the Choice Program into the implementation of the Veterans Community Care Program. While VA did take steps to better prepare facilities, such as implementing new technologies to help manage appointments, conducting readiness assessments of facilities, and providing facility staff with training, 8 of the 10 recommendations that were intended to inform the implementation of the Veterans Community Care Program continue to remain open. A number of our concerns predate the implementation of the Veterans Community Care Program. Specifically, in 2013, we recommended that VA establish an overall wait time performance measure for its community care programs. In 2018, we also found that the appointment scheduling process VA designed for the CHOICE program was not consistent with statutory requirements to receive care. Although we recommended that VA develop an achievable wait time measure for its next community care program, 2 years into the implementation of the Veterans Community Care Program, VA still does not have an overall wait time performance measure for the appointment scheduling process. Without an overall wait time measure, VA and others are not able to know whether veterans are actually receiving timely access to medical care. GAO believes Congress should consider taking action to require VA to establish an overall wait time measure for veterans in order to measure and monitor the timeliness of appointments and to be able to compare the timeliness of community care appointments to those that occur within VA facilities. We also reiterate 2 prior recommendations from the CHOICE report in a report on the Veterans Community Care Program. First, that as VA develops and implements the program, it should design an appointment scheduling process that sets forth steps with timeframes that account for the entire appointment scheduling process. As we describe in our report, VA has only done this for a portion of the process. Second, that VA develop a comprehensive policy directive that provides definitive, up-to-date information on the community care scheduling policy. As we note in our report, policies for the appointment scheduling process continue to be scattered across various policy guidance documents. We also make 3 new recommendations in our report. First, we found that VA's policies are inconsistent or silent on 2 performance metrics that VA is currently using to monitor the timeliness of appointment scheduling. For example, VA is currently using a 7-day performance metric for reviewing a referral. The VA policy indicates a referral should be completed in 2 days. Accordingly, we recommended VA align its monitoring metrics with the timeframes established in the scheduling process. Finally, we also recommended that VA take actions to remove any barriers to community provider enrollment and to ensure an appropriate level of facility staffing and resources are in place for timely processing of referrals and appointment scheduling through the community care program. As we describe in the report, for Region 1, the first region to be fully implemented, many of the facilities were not meeting established timeliness metrics for processing referrals and scheduling appointments. In summary, many of the issues that VA is facing with its community care appointment scheduling and monitoring processes are longstanding and predate the Veterans Community Care Program. And it's important to remember the impetus for expanding veterans' access to care in the community to help ensure veterans receive timely access to care. If VA is not able to effectively monitor and measure how long it takes a veteran to receive care through the Veterans Community Care Program, it will be difficult to know whether VA is actually achieving this goal. This concludes my prepared statement. I'd be happy to answer any questions that you might have. Thank you.
Thank you, Ms. Silas. And now, Dr. Lieberman, you're now recognized for 5 minutes.
Good morning, Chairwoman Brownlee, Ranking Member Dunn, Chairman Takano, and Ranking Member Rowe, as well as the members of the subcommittee. Thank you for the opportunity to discuss the veterans' access to community care since the Department of Veterans Affairs implemented the Mission Act of 2018. I am joined today by Dr. Mark Upton, Acting Assistant Undersecretary for Health for Community Care, and Dr. Jennifer McDonald, Chief Consultant to the Deputy Undersecretary for Health. VA is honored to deliver health care for the more than 9 million veterans who entrust us with their care, and is proud to serve as the backstop to the nation's healthcare system. The COVID-19 pandemic has challenged VA and every healthcare organization around the globe. We firmly believe that it showed the world what we are truly made of. We acted swiftly and decisively to keep veterans and staff safe and excelled in our 4th mission, supporting 47 states, the District of Columbia, and tribal nations, protecting the communities where veterans live and thrive. We remained open for in-person care when clinical urgency rose above the risk of COVID-19, and we reinvented methods of providing routine care by expanding telehealth video appointments by over 1,000%. Despite the world's disruption of the supply chain, we allocated personnel and equipment between facilities as needed. Before the pandemic, VHA was amidst a tremendous transformation, working to unify the direct and community care aspects of the enterprise to empower veterans with more choices while modernizing our systems to enable an optimal experience. We are actively streamlining referral management and automating claims processing to ensure that claims are paid quickly and consistently while being excellent partners to our vast network of community providers. As a part of this transformation, we establish timeliness metrics aligned with the moments in the care experience that matter to veterans and are actively monitored and managed by leadership in the field and central office. VA continues to be efficient with urgent referrals, consistently delivering care in under 2 days, both in the direct system and in the community. We know veterans are resilient and that they often are caring for others. So we want them to know that when they need care and support, they can count on us to deliver it timely and with excellence. We are working with our referral coordination initiative to streamline processes and more optimally engage our community provider partners. We pledge our commitment that any care that was delayed or canceled during the pandemic will be followed up on, despite the potential demands of COVID and flu season this fall. We strive to be the most accessible and convenient healthcare system in history, and we appreciate that you have given us the tools to do so. Our community network of more than now 1.2 million providers complements care delivered in our direct system and together represent an unprecedented range of choices for veterans. We are approaching timeliness and scheduling enhancements with the same tenacity as other aspects of the Mission Act. Our ongoing modernization and focus on safety and experience in these unprecedented times is clear evidence of our commitment. This concludes my testimony. My colleagues and I are prepared to answer any questions that you may have.
Thank you, Dr. Lieberman. And finally, I'll now recognize Mr. McIntyre for 5 minutes.
Chairwoman Brownlee, Ranking Member Dunn, and distinguished members of the subcommittee, on behalf of all of those of us associated with Tri-West Healthcare Alliance, it is an honor to appear before you today. We've been serving the military and veterans population for 25 years. For the last 7, we've been serving in support of VA, from PC3 to the Choice Act, to replacing HealthNet, to handle the rest of the country, to the Mission Act, and now CCN. We've remained focused on one objective: to nimbly support, not compete with, the VA in providing timely access to high-quality care for veterans. Through the use of our proven demand capacity process, we tailor quality networks in collaboration with VA to match the demand of what's needed to support the VAMCs. Our network, which will soon contain all academic affiliates, has now delivered 31.5 million appointments in support of VA. This includes 450,000 urgent care encounters, 22,000 flu shots in the last couple of weeks, 800,000 eye appointments, 600,000 PT appointments, 150 urology appointments, expanded community-based telemental health services, women's services, 235 transplant cases that saved the lives of those in uniform, and everything in between. We in VA collaborate in administering the IVF benefit for those who otherwise could not have a child because of their combat-related injuries. We customize the network and support the unique circumstances of every couple, several hundred of them, including one that is now the proud parents of 3 kids, including a set of twins. As a result of a great team effort, I'm pleased to report that we are now processing paying claims, both professional and institutional alike, within 2 weeks to a level of accuracy in excess of 98%. And VA is reimbursing us timely as well. Along with these successes have come some challenges at each stage of the journey, including the focus of this hearing, and that is the timely delivery of appointments. Let me try and put this in perspective. In the earliest days of VA community care under PC3, I was horrified, as we all were, to find that it took 90 days to get the veteran to the boundary line and in our hands, and 90 days to get them seen in the community. We all made a commitment to go to work, and we worked our side of it. By early 2017, we were scheduling 90% of all appointments within 5 business days of receiving the VA authorization for community care, and the veteran was being seen on average in 22 days. Then our nation was hit with COVID, a challenge that is unprecedented in our lifetimes. Community providers and VAMCs alike were impacted as they sought to make their environment safe for their staff and for patients, and to preserve capacity for those fighting the virus. It was a daunting task. But since July of this year, we are scheduling appointments on our side within 4 to 5 days, and 90% of appointments result in a veteran being seen within 26 days of a referral for primary care, 27 for mental health, and 28 for specialty. And this includes those veterans that ask for more time than the standard to be seen. Veterans with clinically urgent and emergent care are being seen within the standard of 2 days, and only 1% of the care requests are being returned for no network provider. Tomorrow, at VA's request, we begin supporting the first 6 VAMCs in CCN Region 4 with appointing. And we expect the elasticity that we will be providing these facilities will allow us together to, in short order, get to the timeframes that we expect. TriWest applauds this committee's continued leadership and direction as we continue to work toward the goal that we all are united by, and that is providing quality, timely care for our nation's veterans. They deserve no less. Thank you.
Thank you, Mr. McIntyre. And we will now proceed to questions, and I will recognize myself for 5 minutes for questions. So my first question is to Ms. Silas. So, Ms. Silas, can you tell us when the VA first made GAO aware that the reason the department had never established a community care wait time goal, actually despite concurring with GAO's recommendations dating back as far as 2013? Is it because, according to VA, it wasn't statutorily required? And please also tell us, does it typically take, in your opinion, an act of Congress for VA and other executive branch agencies to implement GAO recommendations? Ms. Silas.
Thank you, Chairwoman Brownlee. So we learned of VA's response to developing an overall wait time goal during the course of this review for the implementation of the community care program. When we asked VA about why they had not established a overall wait time, they said that it was because it was not statutorily required. In response to your second question, I know for the choice program, there was a statutorily required 30-day time frame for veterans to receive care through the community care program. During the assessment of the choice program, VA was not able to meet that 30-day requirement generally. We found that the appointment scheduling process itself for the choice program, it could take up to 70 days for a veteran to receive care through the community care program, even though it was statutorily required to be 30 days.
Thank you for that. Dr. Lieberman, can you tell us why did VA wait 7 years to tell GAO that the department needed statutory authority to establish these wait time goals?
So first of all, I just want to make it clear that we are as concerned as you are, Madam Chairwoman, about timeliness of care. And we certainly appreciate outside consultants' opinions, and we have worked with GAO and given them our opinion as time has gone on. I'm unfamiliar with who made the claim about the statutory, that it needed to be statutory. We certainly have always believed in performance metrics, and that's why for urgent referrals to the community, just like within VA, we want to ensure the veteran is seen within 2 days, and that has occurred, we're proud to say, throughout COVID. We certainly are monitoring the time it takes to schedule an appointment, and that is unacceptably too long. And we are also monitoring the time it takes for that appointment to be completed. But things have changed in healthcare. And let me give you 2 very brief examples. How this
Briefly.
how it impacts on the veteran. If I want to have a cataract surgery and I want to go to the community because I'm eligible, and I want the best cataract surgeon in the state, I may have to wait longer. If we were to put on a requirement for a time frame, we may lose a lot of providers who are unwilling to move a veteran ahead. The other is I may, in the middle of COVID, want to wait 30 days for it to put out that surgery because I want to go visit my family members. These are just some examples.
I understand. I understand where you're going with that. I just think that since we have wait time goals for in-house appointments within VA medical facilities, it just is astounding to me that we wouldn't have similar wait time goals with regards to community care. The whole purpose of the Mission Act was to be able to fill a void, if there was one, where a veteran couldn't receive a particular, his or her particular need through the VA, but most importantly to say, we don't want you to wait longer than X amount of days, and so we're going to provide the community care. And the reality is that the community care now is taking longer than it is within, on average, within a VA facility. So I just believe that, you know, without setting some goals and timelines, why would the VA even try to meet? You know, why would they try to improve upon it? I hear what you're saying about you, and I believe you when you say we care about our response time and timeliness to care. I absolutely believe you. But for a big organization like the VA, largest healthcare delivery system in the country, not to have standards and goals of which to operate by nationally across the country is just, it's just absolutely astounding to me. So my time is up, and so I will yield and turn to Dr. Dunn for 5 minutes of questioning.
Thank you very much, Madam Chair, and thank our panelists for being here. I appreciate you taking the time. I will try to keep my questions short. I ask you to do the same with your answers. Dr. Lieberman, you and I have been forced in the past, in our professional past, to work in triage situations. Would you consider our current situation vis-a-vis the pandemic a de facto triage situation just over the last 7 or 8 months?
So first and foremost, safety of our veterans as well as our staff was the priority. And therefore, we saw only in person when the risk of missing an in-person appointment was
So you're not taking all comers like you normally would. You are, in fact, triaging situations.
We are triaging, yeah.
Okay, good. Dr. Upton, this effort to comb through millions of appointments that were canceled due to the quarantine that was instituted in response to the COVID pandemic, does this effort require hundreds, maybe thousands of your staff to devote some part of their attention to the review instead of serving current veteran referral requests?
Thank you. And I would say it's a combination of both for our very dedicated staff. They're both reviewing care that needed to be done before, as well as
Just
processing.
an infinite amount of staff effort.
Well, it depends on the facility and it depends on the clinical needs. And they are very dedicated and have done a great job working through that progress.
Would you characterize the reviewing millions of records for appointments a day to see what happened to them? Is that it's sort of a borderline Herculean task?
I would say our staff are incredibly dedicated and they are working as absolutely as hard as they can to do it, but it's in the best interest of veterans, which is what we're here for. And we are seeing new referrals go out.
Good answer. Again, I'll start with Dr. Upton. This one I might ask Dr. Lieberman for his opinion as well. No one wants a post-action brief and an unvarnished report on how these veterans who had their appointments canceled subsequently received care or did not receive care. But I want to be sure our review process doesn't become an obstacle to delivering community care now, and simply by diverting staff. Can you give me any reassurances on that first, Dr. Upton?
Yeah, absolutely. And I will just say, both as a central office employee here who works in leadership, but also as a frontline VA provider, ensuring our staff are supported are critical. And just very briefly, we're using every tool in our toolbox to assist our staff as they go through that, and that includes
Great
the
staff. And I'm going to just
yeah.
assume, Dr. Lieberman, you'd agree with Dr. Upton. Is that fair?
Yes, amazing staff, and it's everybody on deck to get it right for the veteran that we serve.
Good. So it's normal in medical practice to see widely disparate waiting times for different specialties depending on local shortages and also national shortages. Let's face some specialties are shortage nationally, including family practice and geriatrics. Can you provide, for the record, and I know you can't right this moment, but for the record, we'd like to have a comparison between expected and actual demand and response for high-volume specialties that is, and do so in a variety of localities that are representative of our veterans population. Is that something we can ask for?
Certainly.
Thank you very much, Dr. McDonald. In fact, next question's for you. I hope we have a plan to encourage all of our veterans to pursue flu shots and the pneumonia vaccines, which 40% of COVID pneumonias have a secondary superimposed bacterial pneumonia. I think we can also be encouraging them in nutritional changes and lifestyle changes that can improve their immune status. Are we planning that?
Ranking Member Dunn, yes, we certainly are. Within VA, we've actually delivered 117,000 flu shots already this year, and as of September 1st, this was free to veterans through the urgent cares and community providers. We've already seen more than 32,000 flu shots delivered that way as well.
How about the Pneumovax shots?
Yes, sir, we are encouraging those strongly as well. That's part of the campaign.
And those are provided through the VA, I believe.
They are, yes, sir.
Okay. Dr. Upton, I believe TriWest and Optum both have measures of quality on each of the providers in their panel. Is that quality info available to the community care staff at the VA med centers?
So quality is a very complex discussion. And
I know that. I've hired a lot of doctors.
we are taking all the information we can from the public sector. You know, the public.
But you're talking about a VA med center that's 200 miles away from my town.
Yep.
And, somebody who's never met any doctor in my town, they're going to try to figure out who's got quality, and they're going to have to rely on somebody's measure.
I would say that we are doing everything we can to assess that using what's available publicly, our experiences internally, and I know we're a little low on time.
So the online sites, ouch.
We are sometimes burdened by the quality reporting that is currently occurring, and I know it's a larger improvement, sir, in the
So my time is up, but I tell you what, I have a feeling that, I know that you're all very, very, very busy people, but I have a feeling that we could have a productive conversation, Dr. Upton, and I'd love to spend time with you too, Dr. Lee and Dr. McDonald. I just sort of think he might have the key to some of my data that I'm interested in at this moment. With that, I yield back, Chairwoman Brownlee.
Thank you, Dr. Dunn. And Chairman Takano, you are now recognized for 5 minutes for questioning. And again, thank you for being here.
Thank you, Chairwoman Brownlee, again for this important hearing. Thank you, Dr. Dunn, for that line of questioning. As I mentioned earlier, I'd like to take just a couple of moments to discuss Karma, the Caregiver Record Management Application. That's the name of the IT system VA has been developing to help administer the caregiver program when it expands to pre-9/11 veterans. So Dr. Lieberman and Dr. McDonald, if you could please comment on, respond to my question. Dr. Lieberman first, can you tell us today whether Secretary Wilkie will be certifying the caregiver IT system before tomorrow?
We've had people working really hard on this, and Dr. McDonald, could you answer that?
Yes, absolutely, we will. Pending the Secretary's official certification, sir, and notification to Congress, which is required for us to expand, we do plan to expand tomorrow. We will launch.
Well, I know you plan to expand tomorrow, but will Secretary Wilkie be certifying the IT system before tomorrow?
Yes, sir, that's actually required for the launch. We cannot launch until then. Yes, absolutely.
So you do recognize that the law does require certification, and the launch will occur with the Secretary having certified the IT system.
Yes, sir, exactly. User acceptance testing has been ongoing for months, and actually the first two phases of the system have been live since the winter. This is simply the third phase, now going live and allowing us to certify and expand to Vietnam veterans. We are thrilled to be expanding tomorrow.
Okay, thank you. Are there any known weaknesses in the new system that will not be addressed prior to certification?
We will say this is a beginning, sir. Just as the launch of the new community care program was last year, we continue to enhance on an ongoing basis. So this is viewed by us as a beginning, but it is a very solid foundation. We have reviewed this, and that user acceptance testing has occurred with the frontline staff who are actually using this system. We've also demoed this for VSOs and conducted a wide range of trainings, including for VSOs, and the feedback has been incredibly positive. The staff are very happy with the first two phases and expect to be with this third phase as well.
So are you saying there are no known weaknesses that we should know about?
There are enhancements to be made, sir, and certainly there are adjustments to the IT system that we want to make, but there are no known barriers to going live tomorrow.
Okay. If you could just share with the committee staff what those enhancements, as you say, are or will need to be. Will the new Karma system take over the stipend payments of current participants starting tomorrow?
It actually already has, sir, yes. The new calculation for the stipend payment, consistent with the regulation, will go into effect tomorrow, but actually that's already happening through Karma, and we're very proud of that achievement. And I believe we're actually briefing staff at the end of the day today, so we'll look forward to going through this in detail.
Okay, and you do not foresee any disruption to current program participants and their stipend payments?
Correct, sir.
Wonderful. This is all great to hear. Thank you. This is a question for Mr. Butler and his VSO colleagues. The independent budget VSO's single critical issue for the 116th Congress was the, quote, full, faithful, and effective implementation of the Mission Act, end quote. Since the 116th Congress is nearing its end, what grade would the independent budget VSOs give to VA regarding implementation of the Veterans Community Care Program overall thus far? Dr. Butler, or Mr. Butler, are you there?
Mr. Chairman, I think the grade we can give them is an incomplete. COVID really threw a lot of things under their head, and VA has a lot to catch up with. The implementation of the Mission Act came at the absolute wrong time with the global pandemic. I would say that VA is doing a lot of things faithfully to implement the Mission Act, but they were handed a pretty bad deck in doing so. So incomplete would be our answer.
I won't be so mischievous as to suggest maybe if you were a university that didn't have incompletes, what grade? Never mind. What remaining challenges have you most concerned about the Mission Act implementation? Mr. Butler.
This is Joy Elam from DAV. I think one of the things we want to make sure that is addressed are some of the things that you've heard today, specifically about the scheduling of appointments, the staffing levels, the staffing issues that exist currently, and the volume of referrals that are out there. It's going to take care coordination with the care coordination teams at each facility to make sure that the consults that are needed, that a health status may have changed, that those issues are addressed and that veteran maybe have to be moved up into a more urgent status at this time. But they are facing a daunting task. And I know, VA is working hard to make sure those consults are addressed, but I think a real plan of action, a strategic plan, and more oversight for the field to really help them develop some sort of process that's more streamlined would be helpful.
Thank you. I yield back. I'm sorry for going over my time, Madam Chair.
Thank you, Mr. Takano. And now I look to Dr. Rowe. You're now recognized for 5 minutes.
Thank you, Chairwoman Brownlee. First of all, let's see a show of hands in this room of how many of us have had our flu shots.
I'm getting mine after this meeting.
Oh no, you haven't gotten it yet. That doesn't count. What about the dais? So our 3 physicians have or have not?
You want to go first?
We need to go get your shot today.
Yes.
Okay, I'll start with that.
First,
Well, Dr. Fauci said to wait till October, but
Yeah, anyway, we'll get another one. A couple things I want to go over very quickly, and the VA has had an incredibly challenging, as the entire country has, because of this pandemic. And I don't know whether you've been to a VA medical center during this time or not, but I think they've done a very good job. I've been through mine a couple of times. Tried to stay out because of just the pandemic, but going through, there's a great screening process to even get you in there, which is a very good idea now, and I applaud you for that. One of the things that we mentioned in community care, the COVID epidemic has really thrown a monkey wrench into that because providing care in the private sector, look at my own group, has been difficult. You have patients waiting in the car until it's time for their appointment. And to Dr. Lieberman's point, I'm not telling you when, but I've got to get a colonoscopy, another one. I have one every 5 years. And I could point to the fact that my provider couldn't do it at the time, but that wasn't the problem. The problem was I had to be up here for 3 weeks during September, so most of the case fell on me, not on the provider. And I think figuring that out is as Dr. Lieberman was saying, is hard to do because the patient may have needs and their home, things they do, so that we want to have the choice program or the Mission Act provide the care when it's both convenient and current, and COVID has really hurt that. I do want to go over a couple of things very quickly here, and just if you can help me out, because I know Dr. Dunn didn't have one, I didn't have one, was a course on how to make an appointment in medical school. And this, again, before the Choice Act, and Mr. McIntyre can back me up on this, you could put up the space shuttle easier than you could get an appointment at the VA. And right now, I go through this thing where it says the VA provider creates, in other words, you come to me as a doctor, a referral, and forwards it to the referral coordinating team. The referral coordinator reviews the referral and contacts the veteran. Well, if I'm seeing the veteran already, I usually just say, here, go to the front desk and make you an appointment. It's not really that hard. And the RCT, the team, documents the veteran's scheduling preferences and forwards a referral to the community care staff for review, and then they review it, and then they make the appointment. Well, it's no wonder it takes so long, and I applaud Chairwoman Brownlee for wanting some standards to cut out this 3 weeks that can take just to get an appointment. So I really think you need to look at your internals first. And this question I start with and I have 2 questions. Mr. McIntyre, one, is the problem on the length of time because of COVID or because of this delay I just brought up?
On our side, Dr. Rowe, it's nice to see you again. Just for the record, I've had my flu shot, as has my entire senior management team, so that we can stay focused on the task at hand. With regards, there's 2 parts to this process. One is the time it takes to get from the VA encounter with the provider to us. And then it's from us into the community. And there's two parts to the ladder. And one is to get it scheduled. And the second one is to be seen. We are scheduling when we're doing appointing, we're scheduling within 4 to 5 days. And they're being seen within the time frames that are articulated, even with COVID as a factor. And we in VA are working together very closely to refine both sides of that equation, and we have been for some time.
Thank you. And very quickly, Dr. Lieberman, one of my major concerns, and not just at the VA, but in the private sector, is delay in care. And we know that fewer people have shown up with heart attacks, strokes, various medical, getting their mammograms done during this pandemic. I think the follow-up of patients who've had delayed care is absolutely critical. Could you address that briefly?
Absolutely. First and foremost, if there's any veteran out there who feels like they can't come in for care because of delays, please call us. We have capacity to take care of you. Please reach out. We can often provide it via telehealth. We have been diligently working down the list of the canceled appointments. We are at almost 90% of the canceled appointments since the beginning of COVID. We are over 80% of consults that have been scheduled since the beginning of this year. We have been reviewing them. I want to remind everybody that according to consumer studies, about 20% of consumers still don't feel like it's safe to come in for their health care. So we also are struggling with not everybody wanting to come in for care, but we're doing our best to get everybody to come in and get the care that they need when they need it.
Thank you. I yield back.
Thank you, Dr. Rowe. Before I call on the next member for questioning, I just want to say that I want to be clear that I think the VA has done a fabulous job with regards to COVID and their response to COVID, and certainly your response in terms of an urgent need, meeting that 2-day kind of response time. What I'm trying to focus on here in this particular hearing is the overall structure of what's going on. We know we have the data in terms of what average wait times are. Dr. Rowe just pointed out the beginning parts of that, taking almost 3 weeks to gather all of the information on VA's part is too long. And I think we just need to address some of the structural pieces, which is setting some goals for wait time for community care. I think it's clear that we don't have enough personnel across the board at VA medical facilities. And then we have an IT system that's not working perfectly for us. And so these three things are big sort of structural things to get to the place that we promised we were going to get to, which is to say, if we can't meet your appointment needs within the VA, we're going to do so within the community. And right now we seem to be just the opposite. So I just wanted to be clear where I'm coming from, and I will now recognize Mr. Cisneros for 5 minutes of questioning.
Thank you, Madam Chairwoman, and thank you to the panel for being here today. And Dr. Rowe, I will have my flu shot by the end of the week, just to let you know. Dr. Lieberman, just to kind of follow up on Dr. Rowe's questioning there, but how can the VA better engage with network providers in order to reduce the time between when the appointment is made and when the veteran is actually seen by the provider? And the veteran, they only are really concerned with, how long is it going to take them before they can go to the appointment? That's the only metric they're concerned with. What can Congress do to help improve that metric?
So for us, two things are important as we keep talking about. One is we want the veteran to leave their appointment in primary care where they're referred to a specialist with peace of mind that they're going to get an appointment scheduled within a short amount of time. And we were working hard on that prior to COVID. We are now working on it again with our referral coordination initiative. And we expect to see significant improvements in the time it takes to schedule an appointment. For the timeliness of the appointment, as have been describing, it's each case is different. We want the veteran to be seen when the veteran clinically needs to be seen, and also what impact on their preference of when they want to be seen. Dr. Upton?
Yes, I think that was very well said, Dr. Lieberman, and our focus is the clinical need and the preference of the veteran so that it best meets both entities there. I will just mention, as a frontline VA provider as well, streamlining our processes through the referral coordination initiative, having a veteran leave and having a consistent message to them about their options within VA, both in person and telehealth, as well as in the community. We do track how long it takes for us to schedule into the community, and that data is available. It is challenged because of preference and things like that, but we want veterans to make informed decisions and are committed to doing that and working with Optum and TriWest that when there's an imminent need or a specific situation that we can help a veteran with, we will do everything we can to get them in timely.
So I guess my question really is the problem internally within the VA? Is there any improvement that can be made on making the appointment with the provider? Does that need to be streamlined or made quickly, or is it just it's taking too long within the VA system to actually contact the provider and get the appointment?
I'm happy to take that. I think it's a function of both. That's why we have this referral coordination initiative to streamline those discussions, get that communication out. But our focus is absolutely to then work with those providers, and many of these providers are academic affiliates or other key partners across the country of all types, have very good working relationships with VA, and we work directly with them. There's no publicly reported metric of wait times or accessibility that are out there for our providers, but we do everything within our power to get them in timely, and we want to make the process before that phone call goes to the provider as swift as possible, so then the focus is on getting them scheduled.
All right, thank you for that. Mr. McIntyre, given your involvement in the VA's community care programs for the past 7 years and using your institutional knowledge, can you speak to where VA and the third-party administrators make additional process refinements to further streamline the appointing and care coordinating process, allowing veterans more timely access to community care?
Congressman, thank you for the question. It's, I believe that based on our engaged work with the VA, that they are doing so. They're trying to figure out what are the refinements that they can make to their systems and their processes. It's important for all of us to remember this has been a real challenge, very intense journey that we've all been on, you included, through multiple programs and very quick starts. The VA is to be commended, in my opinion, for designing new systems and tools and processes and putting those in place. As with anything, including the start of the CCN, which we've just done, we go through about a 3 to 6 month refinement process. We're in that zone right now, and it's important to have this dialogue go on. And I would say that the nature of the conversation in this hearing has us focused on the right issues.
All right, with that, I yield back my time. Thank you very much.
You, Mr. Cisneros, and I now call on Mr. Muser for 5 minutes of questioning.
Thank you, Madam Chair. Thank you all very much for being here with us. Thank you for your service to our veterans, as always. Dr. Lieberman, from 2018 to 2019, I understand the sole TPA, or third-party administrator, was TriWest Healthcare. In fall 2019, we transitioned, the VA transitioned to a new community care network contract, which included TriWest as well as OptumServe. Is that all accurate? How was the transition, and why did you have it take place? Why did it occur?
The transition was very important, that it was seamless for veterans, and that's why we did it the way we did, but Dr. Upton can provide more details.
Sure.
Please.
Thank you, Congressman. I would say that, first off, I'd like to thank all of the community providers who have been a part of that transition. They've been through a lot with us, and we are very grateful. We previously had HealthNet covering the regions that Tri-West wasn't covering in the country. That contract expired. Then VA was doing the scheduling, and then we had Tri-West come, who did a great job very quickly to support our care while we awaited this community care network contracts, the future of our community care contracts, learned based on lessons learned from Choice to take over. And now regions 1, 2, 3, which are the Northeast, Upper Midwest, and Southeast, are under OptumServe, and we are fully implemented in that region, and I'm really grateful to have them and Tri-West as continued partners.
Sure. Okay, are you considering additional contracts?
Right now, we have Region 5, which is the state of Alaska. We've made substantial progress there. We'll actually be able to make an announcement tomorrow on next steps. And then we have Region 6, which are the Pacific Islands outside of Hawaii, which are also very critical and currently supported by Tri-West, and we're going to make sure that they are fully supported in a very positive way moving forward.
Okay. Dr. Lieberman, following up on Dr. Rowe's question regarding the delays in service for veterans through the TPAs, Mr. McIntyre was discussing the COVID issue, and clearly that put a real problem for many health systems, of course. But the delays themselves existed prior, and the GAO laid out its report. First of all, just on the findings of the report, briefly, did you think they were reasonable and accurate?
The findings in the report overall were reasonable and accurate. We just disagree on the one recommendation about setting metrics for the community.
Right. And you disagree because, why?
Because one size does not fit all. It's based upon clinical need and the preferences of the veteran for when to be seen, who they want to see.
Right.
And so we really are looking at what is the standard, the gold standard in the community. We've met with the Special Medical Advisory Group. We've had a roundtable on access, and they uniformly tell us that they don't measure wait times in the community because it doesn't reflect what their customers want.
Right. So you don't need an act of Congress to tell you what sort of metrics you should be hoping for, that you should be shooting for.
Correct, and that metric that we're looking for is patient satisfaction scores.
All right, great. Were there delays more with OptumServe or Tri-West?
I would say COVID-19 in particular, especially in the past 7-8 months, have impacted the provider community across the board, some of it very regional specific. And so it really depends on the location, the nature of the care needed. But what I will emphasize very quickly, if I could, is that we had previously not covered telehealth in the community during the pandemic. As we know, providers were not always accepting inpatient visits. We now cover telehealth. There's been over 300,000 visits that way.
Right.
And we've also extended episodes of care so they wouldn't be disrupted.
Good. Some of that will be continued, so that should take some load off and give some alternative methods to access the veterans, correct?
For veteran to receive care, there are multiple ways to access it, and we want to optimize every piece of that inside and outside of VA.
Are there any legislative budgetary constraints prohibiting you from improving this situation?
Not to my knowledge, sir. I'll turn to Dr. Lieberman.
No, there are none.
Okay, great. How was the veteran surveys, by the way? Or are they improving? Did they decline during the COVID, which would be understandable? How are the veteran surveys looking?
I would say the current survey we have for community care is delayed. It's similar to the HCAP surveys in the community. We just started a new survey focused on all the moments that matter in community care. We'll have more data as the months go on, but we're very excited to get real-time feedback from veterans.
Right. Thank you. Thanks again for your work for our veterans. And Madam Chair, I yield back.
Thank you, Mr. Mercer. I now recognize Mr. Sablon for 5 minutes of questioning. Mr. Sablon.
Yeah, thank you very much, Madam Chair, for holding today's hearing. My questions are directed at Dr. Lieberman. Dr. Lieberman, the Department's 2021 budget states that VA will utilize Veterans Care Agreements, VCAs, for providers that are located in Region 6, which includes my district, the Northern Mariana Islands, Guam, and American Samoa. And that is because there was not enough interest to move forward with the CCN procurement process. So VA will utilize the Region 4 contract, which includes Honolulu, when veterans need care in Honolulu or on the mainland. In the interim, TriWest continues to schedule appointments for veterans in Region 6 with community providers under the PC3 program. So what is the status of VA's efforts to enter into DCAs with Northern Marianas providers?
I will defer to Dr. Upton, who can provide the latest information on this.
Sure. And I would just want to reemphasize that the veterans across the country and in the Pacific Islands are critically important to us. And the way that we're approaching that now is we know that there are...
I hear that every time, sir.
No, and thank you. And I will...
I hear that every time from VA, but not from my veterans. Thank you.
Okay. Well, please, I'm happy to be of assistance. To let you know specifically, we have extended the PC3 contract in your area, so those providers and that scheduling support will remain. When veterans from your region go to the Hawaii Islands, they'll have Region 4 to support them, as well as the Hawaii Medical Center. We are going to make sure that we're using all options available to keep them supported. VCAs are just one piece of that, and so I'm happy to keep you updated as this moves forward, and please know it is a priority for us, and I'm happy to keep you in the loop as we move forward.
Well, thank you. And again, I hear that from VA all the time, so I hope that someone will eventually. So in the meantime, how many providers have been identified and have entered into such agreements in the Northern Marianas?
I'll have to take that one for the record, sir, and I'm happy to get back to you on that.
Okay, thank you. Dr. McIntyre's written testimony, a modification to the Region 4 contract will have TriWest assisting VA with scheduling appointments in certain areas. Is the VA considering obtaining the same assistance in managing the BCAs in Region 6?
Congressman, it's great to see you again, and you're there in the office that I was in the Marianas. Thanks for dialing in to this hearing. We're in the process of working closely with VA, as we have done since the start, and we will support them in any way that they deem fit to make sure the great patriots of your part of the world are properly served.
Thank you, Dr. McIntyre. The question was directed at Dr. Lieberman, but thank you for trying to respond. So under the PC3 program, Dr. Lieberman, in place of Region 6, TriWest again schedules community provider appointments for veterans. Under CCN, VA schedules appointments, and as of July 29, 2020, discussions were ongoing on the process for veterans who travel to Honolulu or the mainland care. Has a decision on that process been reached, and if so, what is that process? And I'm really running out of time, so please, Dr. Lieberman.
Dr. Upton.
Sure. Thank you. I think I may need to follow up. I apologize. I just had some trouble following the question there. PC3 is scheduling in the islands, and Hawaii is working with Region 4 to coordinate care for any veteran that comes to the mainland. Please, I'd be happy to meet with you and your staff and talk through all of those and make sure we're supported. I know you're meeting me for the first time, and I'm more than happy to help.
All right, that always happens. Actually, it's 1:30 in the morning where I am. I was hoping that some of you would provide more information than what you're telling me right now. And so I appreciate the offer to work, Dr. Upton, right? Because I hear that almost every hearing I'm given this, we'll work with your office, and then it drops off, maybe because I'm at that part of the world where you were so far the east that if you move a little bit to the right, you drop off from the world. But listen, there are veterans out here who serve their country honorably, and some of who even gave their all. And we appreciate, services to these veterans. They have earned it. It's not a privilege. They have earned it, and they shouldn't be treated any different than a veteran in one of the several states. But they are, to be very honest, they are. And just, we're trying to fix this, working with you and trying to fix it. But apparently, the eagerness on part of the VA is not there because for whatever reason. But thank you very much, Madam Chair. You back.
Thank you, Mr. Sablon, and thank you for joining us, given the fact that it's 1:30 in the morning, your time. You look spectacular for 1:30 in the morning, I will say. And I just want to say to VA, too, please follow up with Mr. Sablon. He works very, very hard to represent the veterans in his area, and I feel his frustration. We all had the opportunity to go there. These men and women who've served, as he said, have served honorably, and they deserve the services and attention from the VA. So please, please follow up. And with that, I will recognize Mr. Brindisi for 5 minutes of questioning.
Well, thank you, Chairwoman Brownlee, and thank you, Ranking Member Dunn, for your leadership on the Veterans Affairs Committee during this pandemic. And I appreciate this subcommittee and all that you guys have done over the past 6 months to ensure veterans receive the care that they need in a timely fashion. I just want to follow up on a couple of questions regarding rescheduling. And I'd like to thank our witnesses for testifying today and first ask them about rescheduling appointments. So my district is in upstate New York. The Syracuse VA Medical Center covers my district. I was recently told that they are in the top 3 in the country in terms of reopening their facilities. However, this week I had a meeting with my Veterans Advisory Committee back home, and I asked them if they had any issues, if had any follow-up from the VA about appointments that were postponed during the pandemic. And for the most part, they said yes. They've been contacted, but they also did get a few no's or a few shakes of the head. So my question is directed to Dr. Lieberman. Do you know how many veterans had routine care postponed or canceled during the pandemic? And can you tell us what the VA is doing to ensure that no veteran is falling through the cracks?
Thank you. That's a very important question, something that we are equally concerned about. We, since the beginning, have had almost 20 million appointments postponed, and we have been able to review about 90% of those already due to the diligence of our staff. And so hopefully those remaining individuals that haven't been contacted will be contacted soon. But we are contacting every person with a canceled appointment, even if it's not believed to be because of COVID. It was another reason. We are reaching out to them to make sure that we are not missing any veteran.
Great, and I'm going to share this with the veterans back home afterwards. So can you offer any recommendations for veterans who haven't heard from the VA after rescheduling their appointment? What should they do?
They should feel free to reach out today, tomorrow, call their primary care team, say, I never got a call, I want to make a follow-up appointment, can you help me? And they will find someone to help them.
And Congressman, if I may add very, very briefly to underscore something Dr. Lieberman said earlier, and just for a moment speaking as a family physician to what Dr. Rowe said earlier as well, any assistance you could provide us as you communicate with them, that please don't wait unnecessary care. Come in and see us. We'll take care of you. We have telehealth options. We can meet you where you are in your own living room, if that's what it takes. We really want people to come in and see us and know that we have the capacity. We know sometimes veterans feel that maybe I should save that appointment for someone who needs it more. We want you to come see us. We're open for business and we want you to come in.
Great. And maybe the VSOs can weigh in too. What would you like to see the VA do better now and in the future to make sure veterans aren't left in the dark when it comes to resuming routine care?
Sir, I think one of the biggest concerns we did here was not following up about some of the canceled appointments, delayed appointments. We know that VA is working diligently with their partners in the community, but communication can always be improved. Communication will set a lot of minds at ease to let them know that they're not being forgotten about, but simply being maybe continually pushed. That would go a long way in helping ease the burden for a lot of our veterans.
Thank you for that. Really quick, I just want to direct a question to Dr. Upton too about alternative therapies. I've got a question on the topic, and I've heard from several veterans and community health providers in my district about problems with acupuncture, chiropractic, and massage care. They say there have been changes to the standard episodes of care in the past year, resulting in a cap of 12 to 24 visits per year. Some veterans are using these therapies to treat service-connected conditions so they can get back to work. Can you tell me more about the changes that were made that introduced this cap and talk a little bit more about alternative therapies?
Absolutely. I will say that the alternative therapies we in VA believe are very important as we work to all modalities to help veterans treat their symptoms such as pain. I had heard recently that there was some confusion about the episodes of care and how long they can go in a year. And so I just would like to assure you and the committee that we've reviewed that. We actually put out guidance this week indicating that when we send a referral out, there's a recommended number of visits. But if a veteran needs more, that medical center can review it and reauthorize that care without concern. So if you hear any concerns from your constituents, please let me know. But we want to make sure our VA providers are aware.
And I'm out of time here, but we'll follow up with you, Dr. Upton. I appreciate that guidance, and we will follow up with you.
That'd be great.
Thank you, Mr. Brindisi. And I think we have a little bit more time, so if members have additional questions, I will allow it. And I will allow myself 5 minutes to ask additional questions starting off. So first, Dr. Lieberman, you know, there's a difference between what is clinically appropriate and operational effectiveness. And so how do you know if your schedulers are performing work as efficiently as possible without some sort of goalposts?
We actually want a goalpost for the scheduling of the appointments. That's what we're working really hard on. That's part of our referral coordination initiative, which we implemented back in January. And unfortunately, there were some delays to that because of COVID. But I am happy to tell you that about 25% of our VA facilities have implemented the referral coordination initiative fully, and another over 80% have implemented in at least 3 or more specialties. So we are making progress with that. That's going to be so critical to getting these appointments scheduled timely.
So what are the goalposts and how many days are we talking about?
Well, as you pointed out, right now we're over 20 days, and that is just so unacceptable. And so we will work to continue to improve that. Ultimately, our goal will be to have that appointment scheduled within 3 days, and that is a big goal to attain, but we intend to get there over time.
And do you think you're able to get there with the current personnel that you have? It seems to me that one of the things that the GAO report pointed out was in the medical centers across the country, you know, X amount of personnel has been appropriated. That appropriation is not really meeting the goal of personnel that they believe that they need, but even further, they're not hiring enough people. They're not hiring and meeting the appropriated goal. So it seems to me that's another big problem when it comes to timeliness and efficiencies on the beginning end of all of this.
Dr. McDonald, would you like to answer?
Thank you. Chairwoman, you encapsulated it so well earlier when you said this is about essentially people, process, and technology, the 3 pillars of any major strategic change, and I would add communications in there is another piece. You're exactly right that we are honing in on making that process easier for the staff we have. We also need to enhance the number of existing staff working in this space. And third, to what you mentioned earlier, this data is not easy to capture. It's not easy to capture veteran preferences in this space, and so we are having to strategically look at our technology to understand how that can support and streamline this. All of those pieces are necessary, and the change management and communication with veterans and with our staff is critical throughout this, so we share your goal on this.
Great. And, you know, I know in the VSO's testimonies, they pointed out that, and I think that they have been asking, they can correct me if I'm wrong, but they have been asking why can't veterans just, you know, ultimately, can we get to a place where veterans just can call and make their own appointment, understanding that they have already been cleared in terms of eligibility, et cetera? Why can't they just pick up the phone and make the appointment? You know, they would have a list of all the providers, you know, within their network. Will we ever be able to get to that place?
Thank you, Madam Chairwoman. I agree. That's exactly one of the things that we're working on, is to allow veterans to have the ability to do that. There is the capability to do veteran self-scheduling now, but just like the other processes, I think it's one we can streamline, and we certainly will continue to make that a priority.
Where is their self-scheduling happening? Where is that happening?
It is possible across the country.
What do you mean it's possible?
It's being done. I can get you, I can look into the specific numbers, but we do have guidance available to allow that to happen. There just are some complexities to the process we're trying to streamline.
Okay. You had said earlier that there are no budgetary barriers, you know, to improving upon the program. It just seems to me that personnel and so forth that need to be hired, that you know, and that's not happening, that might be a budgetary barrier, but.
So we believe we have an adequate budget for this. We're taking a look at the referral coordination initiative implementation, and ultimately we believe that we are streamlining, cutting down steps in the current arduous process. We're going to cut steps down, and so it'll actually get easier to schedule both within VA and in the community. And so we're looking to simplify it, so hopefully in the long run we won't need as many staff.
Okay. I have just been told that the WebEx went down, so the subcommittee will be in recess until it's fixed.
Everyone, I think we might have this working once again. Can someone in the room please confirm that you can hear everyone on the WebEx?
I could just hear you. Mr. McIntyre, you want to say something so we can determine whether we can hear you or not?
Madam Chairman, it's a
Madam Chair,
privilege
one of the
to be
staff,
in
can you
all your company.
unmute your microphone,
Terrific.
please, and just confirm that you can hear us?
I can confirm that, I believe. Are we ready to go?
I believe we are, Madam Chair. If you want to just give us a 5 count in, and then we can resume the hearing. Apologies for the technical difficulties.
5, 4, 3, 2, 1. We will now reconvene. This committee is back in order, and I will call on Dr. Dunn for 5 minutes of questioning.
Thank you very much, Madam Chair. I want to ask a couple of questions, but the first thing I want to do is associate myself with the last question and comments of the Chairwoman Brownlee about the veteran. Once give them the authority, approve the referral, give them a list of who they can choose from, and let them schedule the appointment. I mean, we all know that this makes much more sense. It's much faster. They'll be much happier because they will frequently have their own biases about who they want to see, what they want done, and whatnot. So I mean that would help the VA enormously, and it would certainly improve satisfaction. So I just want to associate myself with those comments. Dr. Lieberman, what mechanisms are in place to measure the satisfaction of the community care providers, the providers with the VA, whether it be with the community care system or any part of the VA that they interact with?
Dr. Upton is our local expert on that, so I'll turn over to him.
Excellent.
Thank you, sir. One of the benefits of the new community care network contracts is that both TriWest and Optum in regions 1 through 4 actually have to send out provider surveys to assess their understanding of working with VA, how the process is going. That's very critical to us. That's specific to the community care program. I can certainly look into other pieces about the overall experience with VA, but we are committed. One of the things that Optum also has is a provider advisory group that keeps them updated on how the situation's going, what we can do to improve. And for me, stakeholder feedback is so critical from all fronts, veterans, providers, VA staff, and that is going to be an absolute focus of mine this year.
So I'm glad you're doing that. Let me say that I don't recall the VA ever seeking feedback from me when I was in community care, providing care to veterans. And I did sit on a physician advisory board for Blue Cross Blue Shield, and I don't remember changing them very much either. So I think you probably want direct feedback. Dr. Lieberman, this is a philosophical question. You may want to muse on it, but if you have a hip shot answer, I'd like it. Does the VA need any relief from Congress to improve the timeliness of care, since that's a topic here? What do you need from us to make that better, if you need anything at all?
At this time, we have the responsibility to work on shortening the time for the appointments to get scheduled and working with the third-party administrators to ensure that the veterans are seen when the veteran needs to be seen in the community.
So you don't need us to pass a law? Okay.
We don't need anything at this time.
All right, thank you very much. With that, Madam Chair, I yield back.
Thank you, Dr. Dunn, and Chairman Takano. I recognize you for 5 more minutes.
Thank you, Chairwoman Brownlee. Let me just say at the outset, I'm very excited about the launch of the Caregiver program tomorrow. It's a big deal, a huge deal. It's happening in the middle of a pandemic, and the families who've been waiting for this implementation are going to receive incredible help. And I was only so sorry that one of my own constituents wasn't able to benefit from the program before her veteran husband passed away. She pleaded with me probably 5 years ago, Congressman, do something about caregivers for other generations of veterans. And so let me say that I am very, very excited about tomorrow, and I sincerely hope it goes well. Let me just ask for the VA witnesses, while reviewing the American Federation of Government Employees statement for the record, I was struck by the experiences employees shared of how often community care policies and guidance continues to change, even well after the initial Mission Act go live, and how difficult it is to keep up with each new set of rules that are put in place as contractors change or new initiatives are rolled out. What employees say is that they need more regular communication and more thorough training. Dr. Upton, can you address this? GAO recommended more than 2 years ago that VA develop a comprehensive policy directive and operations manual for the community care program, but according to the GAO's testimony, that directive is still under technical review, and the Mission Act Community Care Program went live almost 16 months ago. So it's unclear as to whether there's an update to the operations manual that reflects all current guidance.
Thank you, Mr. Chairman. And I will just say, as a VA provider who practiced during the choice program and continues to practice now, making sure that we have the most efficient, streamlined guidance for our staff is so important. There's been a lot of changes, as you mentioned before. One of the things in the past that used to be for community care, there used to be multiple different pieces of guidance out there. We've put that together into a field guidebook that is our authoritative source for community care. But I appreciate the GAO's recommendation, and one of the things with the referral coordination initiative that we are doing at VA is to better align access for veterans as a whole, in-house in the community, and we're committed by the end of this calendar year, Dr. Lieberman can speak more to that, to have a unified guidance book to help tie all these things together, especially now that the Mission Act has settled in further and we have the referral coordination initiative standing up.
All right, Dr. Lieberman, is there anything else you want to add to that?
Just real quick, we have started this journey with in-house care separate from care in the community, and that's not been fair to our staff or, even more importantly, the veterans. We wanted this to be as seamless as we can, and that's why we're looking to merge the rules, if you will, into one common location rather than having two separate sources. We want to make sure that everything works in conjunction with each other and it is simplified for our staff and ultimately translates to better experience for the veteran.
Well, thank you for that. Another passage of AFG's statement that gave me pause was where it said that at the VA medical center level, community care staff struggle to triage consults for urgent and routine care in the community because the forms are too standardized. And as a result, VMAC staff have to manually review each and every referral to determine the urgency of the care being requested before proceeding further with care coordination. Dr. Upton, could you comment on this situation? I would have assumed that an urgent consult request would be captured on one type of form that doctors would would be filled out, would reflect urgency, and routine care would be captured on another form. Is this not the case? And if so, is this something that VA plans to address?
Sure. I'd say when it comes to urgent and emergent care, our number one focus is getting the care delivered, getting that care out there and the veteran what they need. I will look into the different consult types. The one thing that I think that they may be mentioning is when it comes to routine care, there is a wide variety of routine care that may be needed in a week or two versus 6 months or beyond, and also the complexity of the veteran's needs and care also need to be taken into account. We've created a triage tool that looks into all those factors and says, hey, this is pretty complex. We need one of the community care nurses to track that and follow it, versus this is more straightforward. So the intent is to really make sure that we're providing the right care to veterans the way they need it, but I'm happy to look into ways to streamline that in the consult type, sir.
Well, I thank you for that. One of the things that's troubled me with the VA leadership is their disdain for working with the unions. And I think it's important. This is an example of where communication could really result in better care for our veterans. So thank you. I yield back.
Thank you, Chairman Decano, and again, thank you for joining us in this important meeting today. Appreciate it very, very much. So I would just close by saying I think this has been an important hearing. I think that we are going to keep a keen eye on watching you and making sure that these improvements that you're speaking of actually happen. I want to, again, as I said earlier in the meeting, I want to recognize the VA for their response to COVID and thank all of the frontline workers within the VA who are working hard every single day. We truly, truly appreciate that. I also want to acknowledge that I'm happy that the VA is finally recognizing and defining a wait time from the time the veteran calls for an appointment till the time that he or she receives that appointment. I think that's progress in and of itself. We've had many hearings on the complications and calculations of wait time, so that is absolutely an improvement. I'm curious to know whether you actually inform a veteran when you're trying to arrange appointments with them in the community, whether you inform them that it actually may take longer to get a particular appointment in the community than it would within the VA, so that they have a clear choice. But I think there's a lot of work to be done. I appreciate the VA providing the data that they have provided in terms of the wait times. It's always hard for us to oversee this work when we don't know what we're shooting for. And I'm still not clear on what we're shooting for in terms of timeliness and response. But we, as I said, will be watching very, very carefully, and I hope that we can improve upon this program and take advantage of the lessons learned through choice, and really provide the program that we all wanted, which is to say, if we can't meet a need of a veteran in a particular time frame, that veteran will be able to access their health care in the community in a more timely fashion than what the VA can offer. So with that, all members will have 5 legislative days to revise and extend their remarks and include extraneous materials. This hearing is now adjourned. I am so sorry, Dr. Dunn.
I know it wasn't. Community care, it's not just timeliness in making appointments.